I want you to take a quick look at your wrist right now. Are you currently wearing a smartwatch?
Or maybe, one of those high-tech fitness rings.
Right, yeah. Because if you are, you actually belong to this massive and, well, rapidly growing club of people who are just constantly tracking their own heart rate, blood oxygen, sleep cycles, all of it.
Oh, absolutely.
Huh.
I mean, we check this physiological data the exact same way we check the weather app on our phones now. It's just constant.
It really is. But here is the multi-million-dollar question for this deep dive. What are those numbers really telling you?
And that is a question we desperately need to answer because, frankly, we are drowning in our own physiological data.
Yeah.
We tend to treat these numbers as if they are, absolute infallible truths about our health, when the biological reality is, well, it's far more complicated and messy than that.
Which is exactly why we've gathered this really fascinating stack of medical histories, recent FDA warnings, and clinical studies for today's deep dive. Our mission is to unpack the history, the hidden engineering biases, and the true meaning behind our vital signs.
Right. We are looking at the exact metrics that determine whether a nurse sends you home from the hospital or rushes you into the ICU.
But to start, I think we need to lay some basic groundwork, right? Like, what actually makes a sign vital?
Well, if we look at the origin, the word vital is doing some very heavy lifting there. It comes from the Latin word vita, meaning life.
Okay, vita, got it.
Yeah. And historically, most of the 20th century, there were exactly 4 classic vital signs. So that's body temperature, pulse, respiratory rate, and blood pressure.
You'll often see it abbreviated in medical charts as TPRBP, right?
Exactly, TPRBP. And the core thing to understand here, the absolute first principle before we get into any of the history or the tech, is that vital signs are proxies.
Proxies. Okay, what do you mean by that?
I mean, they are not direct, comprehensive measurements of health. They're just a first-pass snapshot, to see if the body's core life-sustaining systems are functioning within a survivable, stable range.
Yeah. Okay, let's make that concrete for everyone listening. Because it sounds like vital signs are essentially the warning lights on your car's dashboard.
Oh, that is a brilliant way to frame it.
Yeah, like, that little check engine light or the battery indicator. They don't tell you exactly what is wrong with the engine. They just tell you that something critical is happening under the hood, and a mechanic needs to pull over and look deeper.
That's exactly it. Your pulse is a proxy for cardiac output, like how much blood your heart is actually moving.
Right.
And your respiratory rate is a proxy for your body's metabolic demand and its acid-base balance. They measure very narrow physiological variables.
It makes sense.
Yeah. But because they are just proxies, they can totally mislead us if we interpret them in isolation, without understanding the actual mechanics behind them.
Right. And if our baseline for these numbers is just a proxy, it really makes me wonder how accurate that baseline actually is.
Well, that's where things get wild.
Because to figure that out, let's look at the most famous number we all take for granted, right? The supposedly universal standard of normal body temperature, which is 98.6 degrees Fahrenheit.
Or 37 degrees Celsius. And it is treated like a fundamental biological law of nature.
Oh, totally. If you are a parent, it is the exact number you are constantly looking for on the thermometer.
Right, but its origins are actually deeply human and historically specific. It comes from a 19th century German physician named Karl Reinhold August Wunderlich.
Okay, Wunderlich.
Yeah, and back in 1868, Wunderlich published a truly massive data set. He spent roughly 2 decades taking axillary, which means armpit temperatures.
Wait, armpit temperatures for 2 decades?
Yes. He took over 1 million readings across 25,000 patients in the city of Leipzig.
1 million armpit readings in the 1860s. Even with 19th century technology, you just have to respect the sheer dedication to the data there.
Oh, it's a monumental effort. And from that specific data, he established the 98.6 degree standard that we have basically used in clinics and hospitals for over a century and a half.
But according to the medical histories we are looking at today, Wunderlich's number is actually wrong.
Well, yeah. Or at least it's wrong for us living right now.
It feels like an outdated software default setting that just never got patched,
It absolutely is an unpatched default. Because in 1992, researchers led by Philip Makowiak published this landmark study in the Journal of the American Medical Association.
And what did they find?
They re-examined Wunderlich's standard using highly accurate modern electronic thermometers. And they found that the modern mean oral temperature is actually closer to 98.2 degrees Fahrenheit.
Wow. So 98.2, not 98.6.
Exactly. Furthermore, the normal range of human temperature is so wide that Wunderlich's 98.6 actually sits near the upper middle of the modern range, not dead center like we always thought.
So we've just been operating on a skewed average for a century. That's wild. But it doesn't stop there, right? Because there was that 2020 study in the journal eLife by Protsev and colleagues.
Oh, yes. The Stanford study.
Right. They looked at health records from Union Army veterans in the 1860s all the way up to a modern Stanford clinical cohort.
And what that historical sweep revealed is just staggering. Average human body temperature appears to have been dropping by roughly 0.03 degrees Celsius every single decade since the mid-19th century.
Wait, our bodies are literally cooling down over time. How is that physically possible? Like, what is the mechanism there?
So the most plausible link is actually to a massive reduction in chronic infections and systemic inflammation in modern populations.
Oh, okay.
Think about daily life in the 1860s. I mean, people lived with untreated dental infections, tuberculosis, chronic wounds, dysentery, poor sanitation. There were no antibiotics.
Right, right.
So because of that constant microbial assault, the average person simply walked around with a higher baseline of immune activity.
And the immune system fighting those constant battles generates heat.
Precisely. The immune system releases these chemicals called pyrogens, which travel to the hypothalamus in the brain.
Which is like the body's internal thermostat, right?
Exactly. And the pyrogens tell it to dial up the heat to make the body less hospitable to bacteria. It is literally like an engine constantly idling at a higher RPM.
That makes so much sense.
Yeah, so as public health, sanitation, and modern medicine improved, our baseline inflammation dropped, and so our baseline temperature dropped right along with it.
Just think about the last time you went to the doctor and they told you your temperature was 98.6. You probably felt this wave of relief.
Sure, we all do.
But normal is actually a moving target. It fluctuates based on the area you live in. We also know it fluctuates based on the time of day, right? Like diurnal variation.
Yeah, diurnal variation, where you are coolest in the morning and warmest in the evening. And it even changes based on where on the body you take the measurement.
But this raises a wild question for me. If the human average is actually dropping historically, does that mean our clinical definition of what constitutes a fever should be dropping too?
And that is exactly what the medical community is actively debating right now.
Really?
Yeah, because if your true baseline in 2026 is, say, 97.5, a temperature of 99.5 might actually represent a really significant immune response for your specific body.
Even though it doesn't cross the traditional 100.4 degree threshold for a clinical fever.
Right. It might be a fever for you, even if the textbook says otherwise.
Man, if our baseline for temperature is literally changing over centuries, it makes me wonder about the other numbers on the monitor. Do they have the same blind spots, or is there one we can actually trust?
Well, let's contrast two of them, actually. The oldest, most neglected vital sign, and the newest, most high-tech one.
Oh, I love this. I want to start with the neglected canary in the coal mine, which is respiration.
Systematic observation of respiration and pulse was championed by Florence Nightingale during the Crimean War back in the 1850s.
Florence Nightingale, yeah.
She realized that careful, continuous bedside observation, not just rapid surgical intervention, was the key to preventing mortality in British field hospitals. She actually codified this in her 1859 book, Notes on Nursing.
But today, respiratory rate is often just totally brushed off. One of the papers we looked at, a 2007 review from the Medical Journal of Australia by Criticos, flat out calls it the neglected vital sign.
It really is.
And the reason is shockingly human. Because you don't need a fancy machine to measure it, clinicians often just glance at a patient's chest and guess the number, rather than standing there and counting breaths for a full 60 seconds.
Yeah, it's unfortunately the only classic vital sign you can easily fake chart.
Wow, fake chart.
I mean, you can't guess a blood pressure without a cuff, right?
Yeah.
But you can write down 16 breaths a minute based on a 3-second glance. But skipping that 60-second count is incredibly dangerous.
It feels like skimming a book and just guessing the ending based on the cover. Like, you are going to miss the actual plot twist.
And in this context, the plot twist is usually a life-threatening complication. Respiratory rate is frequently the very first sign that a patient is deteriorating.
Why is that, though? Like, what is the connection between the lungs and, say, an infection in the blood?
It all comes down to acid-base balance. When your body is under severe stress, like if you're developing sepsis from an infection, your cells aren't getting enough oxygen.
Okay, so they're starving for oxygen.
Right. So they switch to an emergency energy system that produces lactic acid as a byproduct, which means your blood literally becomes more acidic.
Okay, the blood is turning acidic. How do the lungs fix that?
Well, carbon dioxide acts like an acid in the bloodstream. So when the brainstem detects that the blood's pH is dropping dangerously low, it basically hits the panic button.
So it forces the lungs to work harder.
Exactly. It forces lungs to breathe faster and deeper, to blow off as much carbon dioxide as possible to balance out the acidity.
Oh, wow.
Yeah, so that rising respiratory rate can signal impending disaster hours before the heart rate spikes or the blood pressure collapses.
Ah, so the lungs are physically compensating for the acid in the blood, and yet we ignore the low-tech sign that could give us hours of warning.
Yes, often we do.
Instead, we put all our faith in the youngest, highest-tech vital sign, which is oxygen saturation, or SpO2. We measure this with a pulse oximeter. You know that little glowing clip they put on your finger?
The pulse oximeter was discovered in 1974 by a Japanese bioengineer named Takuo Oyagi.
Okay.
He was actually working on ways to measure cardiac output, but he figured out that the pulsatile component of light absorption through tissue could be used to calculate how much oxygen is saturating the hemoglobin in your blood.
Let's break down that mechanism really quickly. Hemoglobin is the protein in our red blood cells that carries oxygen, right?
Correct. And oxygenated hemoglobin absorbs infrared and red light differently than deoxygenated hemoglobin.
Okay, so it's all about how the light passes through.
Right. The pulse oximeter shines both types of light through your finger, measures what comes out the other side, and runs it through an algorithm to give you a percentage. It became standard in ICUs in the 80s, and then, obviously, during the COVID-19 pandemic, it became a household item to detect silent hypoxia.
But the lasers is flawed. And this is a massive systemic issue. A 2020 study in the New England Journal of Medicine by Stoding found that pulse oximeters can be systematically wrong, depending entirely on who is wearing them.
This was a huge deal. The researchers analyzed tens of thousands of patients, comparing the pulse oximeter readings on their fingers with direct arterial blood gas tests.
And that's the gold standard, right?
Yes, that is the gold standard where a clinician actually draws blood directly from an artery to check the true oxygen level in a lab.
And the gap between the finger clip and the lab test was just startling.
It was. They found something called occult hypoxemia. This is a state where a patient's true blood oxygen is dangerously low, but the pulse oximeter on their finger says everything is perfectly fine.
That sounds incredibly dangerous.
It is. And the studies show that this dangerous false reassurance was nearly 3 times more likely to happen in black patients than in white patients.
3 times more likely. I mean, it sounds like trying to use a standard camera flash in a dark room versus a bright room. If the algorithm assumes everyone reflects light the exact same way, it's going to miscalculate the image based purely on the canvas.
That is exactly the engineering failure at play here. The optical sensors rely on passing light through the skin, and skin pigmentation, melanin, naturally absorbs and scatters light.
Right, which the algorithm didn't account for.
Because the original calibration cohorts for these devices back in the 70s and 80s likely lacked diverse representation, the algorithms just don't account accurately for how darker skin tones interact with those specific light wavelengths. It actually led to a formal safety warning from the FDA in 2021.
And it isn't just skin tone that fools the machine, right? If you have carbon monoxide poisoning, the pulse oximeter will also give a falsely reassuring high reading.
Oh, yeah. Because carbon monoxide binds to hemoglobin with an affinity over 200 times stronger than oxygen.
200 times stronger.
Yeah, it literally kicks the oxygen off the red blood cell and
Wow.
takes its seat. But the pulse oximeter can't easily tell the difference between carbon monoxide and oxygen.
So it just assumes everything is great.
Right. It just sees that the hemoglobin is full and spits out a reading of 100% saturation, even while the patient is literally suffocating at a cellular level.
God, it's a sobering reminder that our medical technology is only as good as the assumptions built into it. We are trusting our lives to a glowing plastic clip, just assuming it's infallible.
Which really brings up the danger of relentlessly chasing new numbers. The pulse oximeter shows how hardware can mislead us. But our cultural obsession with creating new, quote-unquote, objective metrics to track has sometimes led to massive clinical failures.
Right, so let's look at blood pressure first as an example of how measurement has evolved to rely on tech. Scipione Rivarocci built the inflatable arm cuff in 1896, but he could only feel the pulse return.
Yeah, he couldn't hear it.
Right. Then, in 1905, a Russian physician named Nikolai Korotkov figured out you could use a stethoscope to actually hear the pressure releasing.
And those are called Korotkov sounds. So when you inflate the cuff, it completely cuts off the blood flow. As you slowly release the pressure, the blood starts to force its way through the squished artery, creating turbulent flow.
And that turbulent flow makes a sound.
Yeah, that turbulence makes a snapping sound. The pressure when the sound starts is your systolic pressure, which is the maximum force when your heart squeezes. When the sound completely disappears, that's your diastolic pressure, the resting pressure when your heart relaxes.
But in 1976, automated oscillometric cuffs were introduced. The machines took over the listening. Today, they are everywhere, right? But automated cuffs have significant flaws, don't they?
They absolutely do. For one, they can misread irregular heartbeats, like atrial fibrillation, and more importantly, they're prone to situational errors.
You mean like white coat hypertension, where your blood pressure is only high because you're stressed out by the clinical environment of the doctor's office.
Exactly. Or the reverse, which is equally dangerous, called masked hypertension, where your numbers look great in the calm clinic, but are dangerously high when you go about your stressful daily life at home.
So a single reading isn't enough.
No, a single, isolated, automated reading is often a very poor stand-in for a patient's true cardiovascular baseline.
But the medical system loves an easy, objective number it can track in a spreadsheet.
It really does.
And that desire for a simple numerical metric brings us to a major controversy in modern nursing: the campaign to make pain the fifth vital sign.
This is a genuinely instructive case study in how good clinical intentions can scale into systemic harm. In 1995, a physician named James Campbell delivered a presidential address to the American Pain Society arguing that pain was being badly undertreated.
And to be fair, that was true at the time.
It was historically true, especially for cancer and postoperative patients. He argued that pain should be assessed and charted just as routinely as temperature or pulse.
So ask the patient to rate their pain on a scale of 1 to 10 every single time you check their blood pressure.
Yeah, and the idea gained massive institutional traction. By the late 1990s, the Veterans Health Administration adopted it. And crucially, by 2001, the Joint Commission, which is the main hospital accreditation body in the U.S., made pain assessment a mandatory standard.
But trying to force a purely subjective human experience like pain into a rigid 1 to 10 vital sign scale, I mean, it feels like trying to measure poetry with a ruler.
That's a great way to put it.
The hospitals needed a metric they could put on a chart, and so pain became a rigid number.
The institutional pressure for measurable compliance was a massive factor here. This well-intentioned push for compassion became rigidly metric-driven. When you combine that with aggressive pharmaceutical marketing at the time, it contributed to a culture of routine, numeric target opioid prescribing.
The idea being, if the number on the chart isn't a 0, you just give the patient a pill until it is.
Exactly. And that dynamic helped fuel the U.S. opioid crisis. It became such a recognized systemic failure that by 2016, the CDC's guidelines explicitly pushed back against using numeric pain scales to drive opioid prescribing.
So they finally reversed course.
They did. And by 2018, the Joint Commission revised its standards to de-emphasize the single pain number in favor of assessing how pain was impacting a patient's broader physical function and, quality of life.
So if single numbers can be historically biased, like temperature, or technologically flawed, like pulse oximetry, or highly subjective, like the pain scale, how do nurses and doctors actually use these tools to save lives?
It's a fair question.
Like, what are these numbers really telling you if they're all so imperfect?
The answer lies in context, trends, and time. A single set of perfectly normal vital signs does absolutely not mean a patient is safe.
Oh, really?
No, not at all. We have to look at the broader physiological goal of the body, which is homeostasis, the body's incredible self-regulating effort to keep everything within survivable bounds.
Okay, so it's about the effort the body is making, not just the snapshot of the result.
That is the crucial distinction. Trends over time and a patient's individual baseline matter infinitely more than population averages. Let me give you a terrifying clinical scenario that busts a major misconception.
Okay, I'm ready.
It's called compensated shock.
Compensated shock. Okay, what is that?
Imagine a young, physically fit 25-year-old who is bleeding internally after a severe car accident. If you take a single snapshot of their vitals, their blood pressure and heart rate might look totally normal.
Wait, I'm confused. If someone is literally bleeding internally, losing blood volume, shouldn't their heart rate immediately spike to pump whatever blood is left? How can they look totally normal on the monitor?
Because their cardiovascular system has immense reserve capacity. The body's incredibly smart. It realizes it is losing blood, so it engages in massive compensatory vasoconstriction.
Vasoconstriction, meaning it shrinks the blood vessels.
Yes. It aggressively clamps down the blood vessels in the arms, legs, and skin to keep the core blood pressure high enough to perfuse the brain and the heart.
So they are sacrificing the extremities to protect the core, and in doing so, they are hiding the internal crisis?
They're masking it perfectly on the monitor, but they can only keep that up for so long. They will maintain that normal illusion right up until they run out of physiological reserve, and then they crash suddenly and catastrophically.
Wow.
By the time their vital signs clearly look abnormal on the screen, it might be too late to save them.
This reminds me of looking at a single frame of a movie. You pull out one frame and you see two people looking at each other. You have absolutely no idea if you're looking at the start of a peaceful romantic comedy or the middle of a high-speed car chase unless you look at the frames before and after it to see the trend.
That is a fantastic analogy. And another massive misconception is that a fever always equals an infection. It doesn't. Elderly patients, neonates, and immunocompromised patients frequently fail to mount a fever even when they have deadly bacterial sepsis.
Right. They can have sepsis with no fever.
Yes, their immune systems simply don't have the energy to generate the heat. They might present with hypothermia, which is a dangerously low temperature, or no temperature change at all. The absence of a red flag doesn't mean there is no fire.
So how do clinicians synthesize all this messy, moving data without getting fooled by a single frame of the movie?
They use higher-order clinical tools that combine these proxies. For example, early warning scores, like the NUWS2 system in the UK, they combine multiple vitals into a single risk number to trigger a rapid response team before a patient goes into cardiac arrest.
No, we also see them use in triage, right? Like the Emergency Severity Index, or ESI, when you first walk into an ER?
Yes, vital signs anchor those triage systems. They also form part of the SIRS criteria, the Systemic Inflammatory Response Syndrome, which is used to flag sepsis. And in neurology, there is a specific late-stage pattern of vital signs called Cushing's triad.
Cushing's triad. What does that look like?
If you see a patient's blood pressure rising significantly, their heart rate plummeting, and their breathing becoming irregular, that specific triad of numbers signals that swelling inside the skull is dangerously high.
Oh my God.
Yeah, the pressure is physically crushing the brainstem, which controls those vital functions.
Wow. So it's the combination, the harmony, or I guess the disharmony of the numbers that tells the real story.
They are incredibly powerful proxies, but they require deep human context to be interpreted correctly.
So what does this all mean for us? To summarize our journey today, vital signs: temperature, pulse, respiration, blood pressure, and oxygen. They are incredible tools that revolutionized modern medicine.
Absolutely.
But they are not absolute truths. They carry historical baggage, like Wunderlich's outdated 98.6. They carry hardware biases, like pulse oximeters struggling with melanin. And they require an understanding of trends and baselines to avoid disastrous clinical blind spots.
And understanding these physiological limits isn't just trivia for nursing students. It is crucial for anyone engaging with their own health data.
Because, going back to where we started, these vital signs have officially moved out of the hospital and into our daily lives.
They really have.
We are using drugstore pulse oximeters. We are using home blood pressure cuffs to try and beat white coat hypertension. And millions of us are wearing Apple Watches, Aura Rings, and Fitbits. We have turned what used to be an episodic clinical measurement into an ambient, always-on data stream.
Which is incredibly empowering, but, only if you understand what those proxies actually represent biologically, and more importantly, what they don't.
Right. So as these sensors get smaller and more integrated into our daily routines, I want you to consider this final thought. What happens when artificial intelligence starts interpreting this 247 ambient data stream on our wrists?
It's coming.
Are we heading toward a future where an algorithm looking at subtle trends in your respiratory rate and skin temperature calls an ambulance to your house before you even realize you're sick? And if it does, will we trust the machine's warning over how we actually feel?